Welcome to Medical Myths, Legends, and Fairy Tales. I'm your host, Dr. Alan Christianson. Look, you know that between the latest online fads and the crazy media headlines, it's easier than ever to get confused about your health. And you and I just want to feel better and live longer. We want to know what works. And we can't wait for further studies. We need to make decisions today based on the best evidence we've got. Well, that's exactly what this show is here for. So let's get to it. So menopause, perimenopause. No secret that many women have difficult symptoms of this change. We can see sleep disturbances, changes in cognitive function, weight changes, hot flashes, night sweats, migraines, much more. And it's also not a secret that HRT can do a good job ameliorating many of these symptoms. But is it safe? Do hormones cause cancer? Are there other health benefits from HRT or not? The data on this has evolved a lot in the last several years, and the perspectives have changed. So I wanted to bring my friend, Dr. Shawn Tassone, to talk this through with you. He's a board-certified OB/GYN. He's practiced for over 20 years and seen over 40,000 women. His role has been that of an integrative health gynecologist. He's been doing a great job writing and staying on top of current medical literature. This is his wheelhouse. So Dr. Tassone will tell us about what's helpful, what's safe, what's not safe, and a whole lot more ins and outs about this topic. So prepare to be surprised. There's some things that are often unexpected. All right, please enjoy this time with Dr. Shawn Tassone. Hey, Dr. C here with you, and I'm joined with Dr. T. Hey, bud, how you doing today?
I'm good. How are you doing?
Good. Yeah, so this is awesome. I can't think of a better guest for this topic, but big thing. So, women can really struggle with perimenopause and menopause. And there's a lot of concern about just hormones could help the symptoms, but are they safe? So I wanted to just talk through these things with you. To kick it off, could you just talk about some of the big symptoms of this transition and some that might not be expected?
With menopause, obviously, we look at things like, hot flashes, mood swings, irritability. Women will talk about that kind of extra 10 pounds that they just can't seem to get rid of around that 45 to 52 age range. But some of the ones that you don't really think too much about or hear too much about because maybe they're not talked about are painful intercourse. Women will complain about painful sex starting in that perimenopausal phase because of vaginal dryness. Sometimes they'll get more stress urinary incontinence. Do see a lot more insomnia. Women just they're not sleeping like they used to, and that just really kind of runs into more of the fatigue during the day and things like that.
And let's even go back one step. I should have mentioned this, but could you just define for us what exactly are perimenopause and menopause, when they come on, when a woman would know that she's going through those?
So basically, menopause is that time frame when you have not had periods for about 12 months consecutively, and you have blood levels that show basically that your that your ovaries are no longer listening to your brain. So there's a couple of hormones called FSH and LH that come from the pituitary gland. And if those are super high, that means that your brain is screaming at your ovaries to make more hormones and they're just not responding. So perimenopause literally just means that time around menopause. And for many women, that can start in the late 30s. But menopause itself is considered normal even up to the age of 40. Anything before the age of 40 to be full-blown menopause is considered abnormal. But the perimenopause phase can last for years and can cause a lot of misery for a long time.
How would a woman know she was in perimenopause?
So perimenopausal symptoms are very similar to actual menopause, but they might not be as severe. So the things that I mentioned, irregular periods being a big one, weight gain, mood swings, irritability, hair thinning, hair loss, just being kind of irritable all the time, and not in situations where being irritable is probably normal, like if your significant other is being a jerk, which we would know absolutely nothing about. But just having that kind of insomnia, vaginal dryness, just a lot of they're pretty much the same symptoms as you might think of for menopause, but maybe not as severe.
So HRT has evolved over the decades pretty greatly, and our understanding of cancer has too. Help us get a sense on why there's been thought or concern that hormones could be drivers of cancer.
Well, when I was in practice in around 1991, they started the Women's Health Initiative, and the Women's Health Initiative was that big study that came out in the mid 2000s where they followed 160,000 menopausal women ages 50 to 79. And what they found was there were problems. They came out with this study that said that there were problems with breast cancer. What the study and what was reported by the news agencies was that breast cancer increased, the risk of breast cancer increased with hormone replacement. What they really didn't tell you was that we already knew what came out of the Women's Health Initiative, because it was always in the package inserts of the medications that we were using at the time, basically Premarin and Prempro. And Premarin is a synthetic estrogen that's made from horse urine, and Provera is medroxyprogesterone, which in my opinion is probably one of the worst medications ever invented. And if you put those two together, you get Prempro, and Premarin was just the estrogen part. So they did a study where they looked at breast cancer risks, and they looked at a lot of things, heart disease, they looked at colon cancer, ovarian cancer, all kinds of things. And this study went on for years and years and years with all these 160,000 women. And what they found was they stopped the arm that had the estrogen and progesterone in it because they found an increased risk in women getting breast cancer. So they shut that arm down. The arm that had estrogen only did not have an increased risk at all. Actually, it actually showed a 50% decrease in the risk of colon cancer, but they didn't really talk about that because it wasn't as exciting. But the problem with the study was that it was just for those particular hormones, Premarin and Prempro. It doesn't really tell us a ton about bioidentical hormones or even other forms of hormones that the newer generations that came out after Prempro. So it really is difficult. But what happened was it became such a newsworthy story that everybody, I mean, I can remember it because I was in practice. Everybody went off their hormones and everybody got miserable. Family practice doctors became super paranoid of prescribing those medications. And it kind of like put Wyeth not out of business, but it certainly sent those two medications off the market. You don't even hardly see them anymore.
They were top sellers for quite a while.
There was just a lot of fear that came out of it.
Yeah, they were top sellers for quite a while before then.
Oh, they were, I think at the time, even bigger than the esophageal reflux medications that are kind of up at the top now.
You know, before that study, I remember there was a lot of talk, and there were those of us who were still doing natural hormones. And the trick was how would you persuade a woman away from what she was doing? People were quite attached to Premarin. And one trick that was done was to take a cup of hot water and drop a tablet in that and let it and let the odor kind of waft around the room.
I used to show them, you ever notice Premarin never went generic? And the reason is a drug can't go generic unless a company can 100% replicate everything that's in it. And Premarin has so many ingredients in it. I think the last infographic that I had, there were like 34 things that were in it, byproducts of equilin, which is horse urine, horse estrogen, and other things. And it had so many ingredients in it, you couldn't ever replicate it.
They were considering making perhaps a synthesized version of that. Is that what the effort was, or?
Somebody, obviously there's always money in generic meds. And that's why Premarin was around for so long, because nobody could copy it. It was not a copyable. Plus the way they made it by, making pregnant mares stand in pee in buckets. It wasn't obviously the greatest thing that they ever thought of. So it was at the time, but it could never be done now just because of the animal rights violations.
So I think breast cancer is often one of the biggest things people think about. So what you're telling us is that from this first study, there was data saying that a synthetic version of progesterone, progestin, did have some strong risk associated with that, but those did not equate even to a non-human estrogen. Is that a fair assessment?
What they said in that study and what came out of it was that per per 10,000 women, the risk of breast cancer was about, with Prempro, the combination estrogen progesterone synthetic, was about 1 in 1,000. And so it wasn't a massive increase, but there was an increase. And if you read the package insert at the time from the company, it basically reiterated that. It's just, those package inserts, nobody ever looks at them. It basically said that. And we know now that if women, the problem with the study is that it was women over the age of 50. Well, what happens in women under the age of 50? It didn't study those women at all. Those women that normally have estrogen in their bodies. The thing with menopause, you're not, if you want to go natural is nothing. Natural is menopause, which is no hormones. But if you use hormones after the age of 50, from the age of 50 to 69, using estrogen for 20 years increases the risk of cancer in breast by about 1 in 50. And that's if you use a combination pill. So if you use estrogen, and again, this isn't necessarily bioidentical hormones. This was done by pharmaceutical companies. So the synthetic hormones, the risks of combination pills is about 1 in 50 from the years of 50 to 69. If you just do estrogen with intermittent progesterone, like you just cycle the patient maybe 10 or 14 days a month with progesterone, that's a 1 in 70 risk. And if you only use estrogen, it's about a 1 in 200 risk.
And the drawback with only using estrogen with an intact uterus is that you could have dysfunctional bleeding. So that's been the rub. Easier with women who had a hysterectomy, right?
Correct. But even then, I used to be of that mindset where if you didn't have a uterus, you didn't need progesterone. But by putting a patient just on estrogen, you could put them into an estrogen dominant state, which at times may not feel comfortable as well. But I always tell patients, and this is what we were talking about when I mentioned this, is that estrogen itself doesn't cause breast cancer. If it did, then every woman alive would get breast cancer because they all have estrogen, and men too, because we have estrogen. So it's not just estrogen that causes breast cancer, as you know. I mean, there's so many things. There's where you live, what you eat, how young were you when you first had your period, and how old were you when you went through menopause, and how many kids did you have, and did you breastfeed them, and genetics, and all of these things play a role in cancer, especially of the breast. And sure, if there is a breast cancer cell in your body that has an estrogen receptor on it, and we are giving you estrogen, it could potentially stimulate that breast cancer cell to grow. But it's not necessarily causing breast cancer in and of itself.
There's a difference between causing a cell to be there and stimulating a cell that's present, huh?
Correct. And we know detoxifying, how a woman detoxifies her estrogen. If she goes down the 4-methoxy detoxification pathway, that's going to cause more DNA damage versus going the 2-methoxy pathway, which we can enhance with things like DIM or cruciferous vegetables and methylation with methylated, people that methylate their vitamins, their B vitamins.
So past the Women's Health Study, are there more things that more refinements that have come out in terms of the distinctions of the synthetic and the natural hormones?
Not so much between the two. The problem with the natural hormones is that nobody really wants to study those because there's no money behind them. So all of the data that gets done, and to be perfectly honest, there isn't a whole lot that goes into women's health because women's health is just kind of always put on the back burner. But the things that we look at that have been looked at with estrogen therapy are going to be what we talked about with breast cancer. We also have, we've talked about ovarian cancer risks. And my mom died of ovarian cancer when she was 56. So I'm a little bit sensitive to this. We haven't shown any sort of, it's unproven at this point. There's really nothing that shows hormone replacement aids or helps with ovarian cancer. Stroke risks are not clear. We know that women that use hormones for less than 5 years, so if they're 50 up to the age of 55, benefits outweigh the risks. So it's currently recommended that women use hormones in the beginning of menopause because the benefits that they get with bones and cardiovascular protection, possibly even help with brain function, is so much higher than the potential risks that we recommend using it. But there's also risk with blood clots. We know that there's about a 1 in 1,500 risk of deep venous thrombosis or pulmonary embolisms. Not a huge risk, but a risk that's there. And I think what it comes down to, I mean, I'll meet with women that actually have breast cancer, and we talk about using estrogen because it really depends on their informed consent and how they feel. You know, this is a woman who can make medical decisions for herself. And if she is miserable and she can't live the life that she wants to live because she's so miserable not having estrogen, we try to find a way to make that as small of a dose as possible to get her back into life, you know?
So there are times even post hormonally sensitive breast cancer where it may be a consideration for a woman, you're saying?
Yes, I mean, especially in a woman that if I've known her for a while and we've had those discussions and she's not functional, she can't have sex because it hurts, or there's ways that you can give vaginal estrogen that might not increase blood levels sustainably so that you're not really increasing the risk. But you know, and hot flashes, and we might talk about this in a little bit. There's other things you can use for the more minor symptoms that aren't necessarily estrogenic, but occasionally, you know, you may have women that have serious bone loss and they don't want to take the bisphosphonates because they don't like the side effects with those medications for osteoporosis. And using things that might be super weak estrogens might be more helpful for them. But there's always going to be risk. But it's like anything else. It's like having surgery. You know, if it's not a life or death surgery, which most of the surgeries I do are not, is the patient going to feel better afterwards? Are they willing to undergo the risks? And what are the risks? And then you let them make their decisions based on those risks.
So along with other factors that you alluded to, they could be in place of hormones or in addition to hormones to help manage symptoms that are still persistent. What are some things you talk about with women as far as other steps they can do to make menopause go more smoothly?
Well, in my clinic, I kind of look at it in 6 steps, and only one step is hormonal. I mean, there are some things as, you know, essential oils. You know, a good friend of ours, Maritza Snyder, is really big with essential oils and using things like clary sage and some other things to help with some of the symptoms of menopause, like hot flashes and things like that. There's, you know, lavender for sleep and things like, so there are other things like that you can try. Nutrition is obviously huge. I mean, we can try to, I don't know if you can necessarily eat your way out of some of the severe symptoms, but you can certainly try to make them better and make your health better by increasing your healthy fats and things like that. You can use certain supplements for sure. One of the biggest supplements I go to in these instances is maca. I'm a huge fan of maca for balancing the hormones, and it doesn't have an estrogenic effect. So it's not a phytoestrogen per se. So it's not going to actually lock and key those estrogen receptors. And then, I mean, I'll even talk to women about, you know, I call them spiritual practices, but things like meditation or yoga practices, or even you know, journaling. There's so many different things that you can try to you know, overcome some of these symptoms. But it's, you know, they're nothing to me. This is, you know, obviously a hormone is going to give you the most bang for the buck. I mean, that's the atom bomb with therapy. You're going to get a fast, quick, big result versus a smaller over time result with a supplement, say. But you could still get the same result. It might just take a little while.
And there certainly seem to be those that just struggle regardless of what they do, you know, even on hormones. Any thoughts about patients that fall under that category?
Well, yeah, everybody's like, I even have patients that sometimes struggle when they get hormones. So, I mean, everybody obviously is a little bit different. I think it's different based on age too. So the younger the woman, so if I have a woman who is, say, breast cancer at the age of 35 and she's on absolutely no estrogen, she's going to suffer and have way more symptoms than a woman who might be 70, because because they're older and they don't have the needs that the younger woman does. The problem is that it's harder to get them more stabilized because they might need more of a hormone effect than an older woman. So those are the women that tend to struggle, are probably the younger women, because they're hard, especially if they're completely menopausal. But then if you flip that, women that are perimenopausal who are still cycling, that may have irregular cycles, they're difficult as well, because they have such irregular cycles that sometimes it's hard to know exactly what hormone is deficient at what part of the month, in what month is it, and so those can be, you just have to be persistent.
So other changes that women notice when they have corrected their hormones, menopause, perimenopause, what are some common benefits you see besides just the relief from the hot flashes?
Well, I see women, this is probably one of the biggest complaints when they're in their 40s. And these could be women that were normally super thin, super fit. It's one of those things where they will say, I've always been 125. I've always been fit. I eat right. I'm still working out the same. And I've literally gained 10 pounds. And it's always 10 pounds. It's always 10 pounds. And it's always around the abdomen. And what I think is happening, fat is good for two things. It's good because it makes you heavier and it makes your bones stress. So the heavier you are, the harder your bones have to work to carry you around. So you are less likely to get osteoporosis with being heavier. The second thing that fat cells do is they aromatize estrogen, so they can make estrogen. So for women that have low estrogen, your body's going to want to hang on to that fat because it wants to make its estrogen. So I joke and say one of the problems is we live too long, and we lived too long too fast. Evolution hasn't really had a chance to catch up to the fact that we're living into our 80s. And so women get menopausal at 50, maybe 500 years from now, women will be menopausal at 70 or 65 because evolution will keep their ovaries going. But right now we have women that are living longer and they're living good, and we want to make sure that they can keep going. So one of the persistent things I think is that weight gain. And if we can get the hormones balanced, or at least as close to balance as we can get them, if you're doing the right things to lose weight, I think the weight will eventually then come off. But I would challenge women to look at their pictures every 10 years, look at a body shot, 10, 20, 30, 40, 50, 60, 70. What you'll see is, if you have family members that are that old, is you get kind of chunky around that 10 to 15 age group. You get puffier in the face, and then you kind of lean out in your 20s, and then 30s and 40s, you've had babies, so you might get a little thicker. But then you get into your late 30s and 40s, and women lean down again, only to get a little bit thicker in their 50s. And then you look at them again in their 70s, and they're usually thinner again. Except for my grandmother, she was an old Italian lady, so she never lost weight. But that's just our genes. But they thin out again because their body doesn't need that estrogen anymore. And so I think if we can supplement that throughout the journey, I think that the hormonal balance is really key for women who are trying to lose weight.
So the times in which they're lean, the body, as you're saying, has the least need for estrogen, the least need for fat to form it?
Yeah, I think if you're, the problem is if you're living your life well and you're skinny and your body gets into this state around 45 or so where it's like, I don't want to lose my bone density, so I'm going to try to hang on to some of this fat because it's preparing. It's almost like, how we prepare for famine. Our bodies are programmed for famine. Unfortunately, we have a lot of calorically dense food, and that's why a lot of us are overweight. But we used to have to live through famines. And I think that the hanging on to the fat is kind of that same concept where our body's like prepares for menopause the best way it knows how, and that's by hanging on to fat cells.
And a lot of my listeners have thyroid disease. I would just love a few comments from you about how the thyroid function and those who are on thyroid treatment, how that changes as they go through perimenopause and menopause.
Well, it's the same. It's like, so the demand is going to be highly fluctuant just based on your weight. First of all, I kind of, people talk about hormonal balance as like a symphony. I like to use a clock, and you take the face off a clock and there's all those gears and they all turn based on how all the other wheels are turning. And if one of them changes speeds, then the other ones change speeds.
Yeah.
And then they don't tell the right time. So thyroid's part of that clock gearing. And what happens is we know that, like, let's say your estrogen levels are super high. Well, that's going to raise your thyroid hormone binding globulin, which grabs onto your free T3 and makes your thyroid have to work harder to produce more thyroid for T3 for you. Same thing if you're on birth control pills, it does the same thing. So all of that, women that go through menopause who have no estrogen, if I put them on estrogen, and I start the machine back up, as it were, and I bring their estrogen levels back up to normal, that could change the dosing on their thyroid, because I'm raising the estrogen levels, and I might be actually making their thyroid hormone not work as well, and they might need to raise their dosages a little bit. So it all kind of works in tandem, and you really have to keep an eye on that with women that are going to go back on hormone replacement.
That's awesome. I'm glad you said that. That's been a pet peeve of myself and my doctors, is that a woman may be on treatment, and same thing for like stopping HRT or stopping contraceptives. That'll undo that level of thyroid binding globulin. So yeah, listeners that may be on thyroid treatment or on the edge of needing thyroid treatment, just do know that any global change in your hormone status will shift your thyroid needs.
Oh, and I always joke, except for thyroid and cortisol, hormones aren't necessary to survive. But thyroid is one of the two that you have to have it to live. And so while if you're going through super stressful periods, in your life, that HPA axis, that hypothalamic pituitary axis, that is so delicate to run, and it's so intricate that if your body is stressed and it needs to do other, it's going to shut that off, because it's got to digest food, it's got to run the heart, it's got to run the brain, but it doesn't have to make your hormones balance. It just needs to try and keep your cortisol and your thyroid gland running, but even they don't have to be balanced per se. So women can go into hormone imbalances quite easily if they're just in a stressful environment, because your body's going to be like, no, I can't deal with this. This network is too intricate. I can't deal with it right now. So yeah, if you start messing with it as a provider, you really got to watch all the other hormones too.
And to further your comment about stress, cortisol has its role in also affecting cell permeability for many hormones. So even if the ovarian output were good, like you're saying about women's stress response, that can change how much cortisol is causing those cells to take up the estrogen and the progesterone and the testosterone. So yeah, it's a super central thing.
It's almost annoying to think about how intricate it is. Just when you think you have your brain wrapped around it, and then you find something else out and you're like, wow, that just throws a wrench in everything,
I was in medical school, and my maternal grandmother long since passed away, but I spoke to her then, and she had some comment about, what a wonderful creation it was with God being able to make a human body and the perfection of it. And I said, yeah, it's pretty cool, but I wish you'd have to put so many parts into the whole thing.
Oh, I know. And then, for men, we are pretty simplistic creatures compared to females as far as hormones go.
Very much so. Yeah. A lot fewer moving parts.
Well, that and just our brains too. I think we're overall very simplistic creatures.
My wife has so many levels of understanding in what she says and what she hears, and the subtext and the undertones, and and I'll say something, and I think that amongst her and girlfriends and her female peers, they often do have a lot of these levels of meaning, but she'll often think that I have some complex level of meaning, and I'm like, nope, it's just with those words, just those words, just put those words together. That's all there was to it.
Yeah, when you were in college and you were reading like some poem, and the teacher would go off on all these different levels of meaning, and you were like, I just thought he was talking about his dog. But yeah, and you're like, no, and that'd be him going, yeah, I was actually just talking about my dog. Yeah.
So my favorite line when those things come up is, hey, look, if there's multiple meanings and one of those made you mad, that's not the one that I meant.
Yeah, it's true. It's totally true. That's a good defense, actually. I like that.
So big picture, menopause, perimenopause, just give us a sense about what this can be like when things are managed well for women.
Well, the first thing that I tell women, by the time they get to me, they've normally seen 2 or 3 doctors, and they're frustrated. They find me because they're on the internet, and it's midnight and they're miserable because they're not sleeping. But they've been to see 2 or 3 people. They've had their hormones drawn, and they are told that everything's either normal or they're just getting older. So when your hormones are balanced, you're not feeling that way. You're not feeling broken. You're not feeling like there's something wrong with you, that you're just getting older. Just because you're getting older doesn't mean you have to be miserable or feel awful. That's a myth. And I think for some reason, I don't know why, but doctors love telling women that all the time. So when your hormones are in step, you sleep better. You feel better. You have energy. You don't feel like you need to take a nap at 3 p.m. You don't feel like your hands are freezing all the time. Your periods are back on track. Usually, they may not be exactly 28 days in length, but they put anywhere between 21 and 35, and they're coming every month. But I think it's just like, what I often joke is that women who have hormonal balance, the people around you are the ones that are going to notice first. Like this lady said, "Oh yeah, my son spilled a glass of milk at dinner the other night." And this is after she'd been working with me for a few months. And he looked at me and he cringed, like he was waiting for the onslaught to come out of my mouth. And she said, all I said was, "Oh, don't worry about it, honey." And he said, "Mom's feeling better." And so that's true, though. It's like, just, you have your wits back. It's just, you can feel normal again.
That's awesome. So menopause, perimenopause can be a big deal. The symptoms might be unexpected. Treatments are available, and risks don't seem to be zero, but they're probably not as bad as one thought. And there may even be more benefit than risk. So Dr. T, any closing words you want to leave our listeners with?
I think just to reiterate that, I always say normal isn't normal if you feel abnormal. I mean, it's not. You are very intricate humans. There are so many moving parts, and any one of them could be off. That could be making you feel badly. And you know yourself better than we do. And for somebody to tell you that you're normal and that you're just getting older, that person needs to not have any friends, because that's horrible. That is a horrible thing to tell somebody that's just not feeling right. There's always something off if you feel like that. No person that I know of is going to go to the doctor if they feel good. They're going to go to see us because they feel like something's off. And then, it's just a range. It's a range that you just have to look at. Where are you in the range? Ask your doctor if they say you're normal. Say, where am I in the range? Am I in the 10th percentile or am I in the 90th percentile? Chances are you're probably lower normal, and that doesn't feel good. So you've got to sometimes be your best advocate.
So that's awesome. You know your own body. Dr. T, thank you for your time. We're going to get links up. People can connect with him over the distance in some ways, and we've got other things that are available for you with his practice. So we'll get those up. And thanks so much for your time.
Oh, sure. Thank you.
All right. Thanks for tuning in. Take great care, and we'll be back again soon with more and back on Medical Myths, Legends, and Fairy Tales. Dr. C signing off. We'll talk to you soon. Bye-bye. Hey, Dr. Christianson here. Thanks so much for joining me for another episode. Is there a topic you'd like me to cover? I'd love to hear from you. Just go to Dr. Alan Christianson on Facebook or Instagram, write your question, and use the hashtag Medical Myths. Did you find this show helpful? If so, please take a minute and leave us a rating on iTunes so that others can know. Thanks much. I'll be back with you real soon. Bye-bye.